Well, croeso nôl, very warm welcome back after our lunch break. As we recognised before lunch, our meeting today is demanding more time than we had scheduled for it, and so we resume our in-public board meeting. But before we come to the item 3.3 on our agenda, I need to take us back, colleagues, if I may, to section 2 of our agenda that I did skip over earlier, and that's to ask, does anybody want to suggest, please, or ask that we remove any item that's currently in section 4 of our agenda under the consent agenda, that we remove it from there and place it as a substantive item on our agenda for consideration and discussion? No one is indicating that they do. Therefore, when we come to section 4, we will operate, as I explained earlier, by considering those items without discussion and supporting them en bloc. So that takes us to item 3.3 on our agenda, and this is our new remodeled, reshaped IQPAR. And I'm going to invite Nicola to introduce this. Just before you do, Nick, let's just remind ourselves of the comment that Katie made earlier in the Slice report in relation to this agenda item, inviting information about improving access, reducing delays, and improving the experience of children and families, and wanting some reassurance that this remains a key priority within our performance management. But with that, over to you.
Thank you, Chair. I'll introduce the report quite briefly due to time issues. So we'll just pick out the key points from the summary, which I think is quite straightforward in the paper. So in terms of the 5 domains that we now report against on quality and safety, there's really good progress on infection prevention and control, and the areas for improvement haven't changed since we looked at this in previous reports. In terms of access and outcomes, we're making good progress on mental health measures, minor injuries unit standards, 104-week waiting times targets as a provider. An area of concern is the diagnostics performance, which has deteriorated since the end of March against the 8-week standard for us as a provider, and we still have an issue with long waits at one of our commission providers, Robert Jones and Agnes Hunt. On both of those latter issues, diagnostics as a provider, Robert Jones and Agnes Hunt long waits, we have had the opportunity to submit a case to Welsh Government in response to a letter from them. There's no guarantee of receiving additional support to tackle those issues, but we have put our plans forward to do that. And that also includes a emerging issue in terms of waiters at Wye Valley NHS Trust, which may transpire towards the latter end of the year. Cancer waiting times and pathways remain variable across providers due to variability in the system across NHS England and Wales. And for urgent emergency care, as we discussed on the EMIRTS and the rural response model in the Chief Executive's report, our population continues to experience longer response times than other areas of the country due to the rural nature of where people live. On children and young people's neurodevelopmental services, we are maintaining our board agreed waiting time ambition of nobody waiting over 104 weeks. And to note that the board did agree to maintain that as the ambition and not to reduce it in the discussion and the agreement of the annual plan, and the balance of priorities between performance, quality and finance. However, we have invested in that service. We continue with the transformation programme, and we look forward to new standards for neurodevelopmental services in the round being published later in the autumn. On population health and prevention, we're good on many of the measures. Diabetes targets still remain challenging, and we continue to dental access also is an area that we keep under review in terms of improvement. On people and culture, we're pleased to report in this report that we're compliant on the agency spend as it's measured in this report, but there will be further information on that on some of the other measures coming through in future reports. And our sickness of our staff remains a cause for concern, and PADR compliance remains an area of improvement. On productivity and efficiency, obviously this is an area of development for us. As we know, it's really important for us in terms of delivery of our sustainable plan, but also a very key interest of Welsh Government in terms of driving productivity and efficiency through the service. So I'm happy to take any questions on that section, but as I say, it remains in development at the moment. So that's all I was going to say in terms of introducing the report. Thank you, Chair.
Thank you, Nick. Colleagues, do please indicate if you have a question or any contribution you'd like to make in response to this report. We'll go initially to Steve.
Yeah, thanks, Nick. Helpful report. Can I just specifically ask a question around urgent emergency care and ambulance response times? I think it's an issue I've raised through Finance and Performance Committee regarding the actions that we are taking as an organisation to escalate the poor performance on ambulance response times through the JCC and through to WAST. You mentioned that obviously we are a rural health board, but the target doesn't differentiate between us compared to other health boards. So I'd just like to understand, taking account of what we discussed earlier today about the consultation that WAS are taking in terms of rural response, but what action we are taking as a board to raise our concerns with JCC and WAS in terms of this performance. Thank you.
Thank you, Steve. We continue to raise it through all the mechanisms that we're involved with in JCC, being the actual formal committee, the Finance and Performance Committee, where Hayley is the Chief Executive Rep, the Commissioning Collaborative Leadership Group, where I'm a rep in my own right, and specifically the Ambulance Commissioning Assurance Group. So we continue to raise it through all of those methods, and in the context of the development of the rural response model, which we would hope would go some way towards addressing this issue.
Could I have a follow-up,
Yeah,
Carl?
please do, yeah.
So in terms of the way that we address it, what is the level of response that we are getting from those various forums that you've just explained?
I would say it's noted. The concern is understood. I think the work, further work on the rural response model and other pieces of work around the measures for ambulances, those are under review as well. The response that we get is that our concerns will be taken into all of those pieces of work.
Thank you, Steve. Yeah,
I think it's still an issue that needs to be pressed, and there is a difference, obviously, a distinction between the EMERTS process, which is part of the rural response model that we referred to earlier, and the what we just generally called normal ambulance responses. So that distinction needs to be recognised as well. Thank you.
Thanks, Steve. I think what I'm hearing, Nick, is it's one thing to raise these matters and to have them noted, but from our perspective as a board, what kind of assurance can we receive that actions are being taken to improve matters?
I understand that's the question. That's what's being heard. I think I've reflected where we're at in terms of representing that to the JCC. I believe this is scheduled for further discussion at Finance Performance Committee in September. So before then, I'll undertake to have a further conversation with Pete and probably with Kate as our medical lead, and think with others around how we may want to formalise our concerns further.
Okay, thank you. And of course, as was mentioned earlier, JCC is with us in one of our board development sessions in October. So we will have a direct opportunity to raise some of these and other matters with them. And but thank you, Steve. Let's go to Rhiannon.
Yeah, thank you, Chair. So I just want to acknowledge the good progress on clinical coding. That's not an easy thing to achieve, so I just wanted to acknowledge that. And I also welcome the new measure that we seem to be including now on readmission rates. I think that'll be quite helpful for us. My more substantive comments are really around particularly as it's a public board, and I know that we will be looking at this in much more detail next Tuesday in the patient experience and quality and safety meeting. But it's about the performance, I guess, around complaints, patient experience and incident reporting. It's just trying to get a sense in terms of our expectations of when we might see some improved performance in those areas. It's probably one for Paul.
Thank you. Do you want to bring Paul in, Nick? Or
yes, please, Chair. Thank you.
Yeah. Paul.
I thought you might, Nick. Yeah, thanks, Rhiannon, for that. And you're right. We have our paper going, our integrated quality report going to PECS next Tuesday, where again we have some detail in relation to where we are on that trajectory. I think that there's a number of things that we look in this space. We have still some historic cases that we need to close out. We've significantly reduced those historic numbers, but still recognise we're not where we need to be, and we have plans in place around how we reduce that. Some of that isn't always in our gift because we're waiting for external responses, coroners, etc. But we're certainly cited on it, and there are plans to reduce that. Since listening to people came into focus in April, our performance against the standards set there is quite good. And again, you'll see that in our PECS report on Tuesday. I don't have the report in front of me now to go into that level of detail. And equally around patient experience, again, we're bringing a final paper back to PECS on Tuesday that looks at ratifying our framework and closing that action that outstanding escalation that's been in PECS for some time now. And again, we addressed that earlier in the meeting today. So by the 1st of September, we will have embedded our patient experience framework and the governance structures, the policies that support that. And I think from and you would have noted again in the previous PECS that we were able to close the action or the escalation around Civica and the number of responses we're getting. And again, you will see in the PECS report this time around that those responses are improving month on month. I recognise within the performance report in front of you, patient experience is still below the national average for Wales. That data is dated in terms of, we're looking at May data. And we've seen a significant improvement in Q4, and we're continuing to build that into Q1 of this financial year. So I think whilst there's still a lot of work to do in this space, we're on the right trajectory, and I feel in PECs next week, we'll get some assurance that we're meeting the targets that we're setting.
Rhiannon?
Yeah, thanks, Paul. I think particularly that the complaints performance is one we would need to pay significant attention to in terms of what we can expect by when, recognising the sort of backstory to this. But we can pick it up next week, as we've said. Thank you.
Thank you. Mick, please.
Thanks, Chair. I just wanted to acknowledge the improvements in the format of the IQPAO. I found it much easier to navigate. It's more logically presented, and it's easier to see what mitigating actions are being taken where things are off track. So just, I wanted to thank Nick and the team for the work that's gone into that. It's an easier read than the previous version. I did actually have a question around what appears to be a disconnect between some of those improving performance trajectories and aspects of patient experience that Paul's alluded to there, but quite happy to take that into PECs for discussion next week, given the time constraints.
Thank you, Mick, and thanks for your comments. So we'll go to Ronnie.
Thank you, Carl. Nicola, as I think you know, I very much approve of the new format of this report. As Mick has referenced, I think it's very much better. A number of observations from me, please. Rhiannon and Paul have already reflected on the patient experience dimension, and I don't want to deal with that substantively again, other than just make the observation that we put a lot of effort into patient experience, and it's disappointing that we're ranking the 9th in Wales. That has to be an issue for concern. And also to say, in relation to Paul's point and Civica and response rates, if I were elsewhere, I'd be looking for a response rate of 10% from patients before it's considered statistically reliable. So, I don't know where we are with that, but I know what my ambition would be for that as an area. Then to say on screening and colonoscopy, you'll not be surprised that I raise this again, Nicola. I think the last position was 20%. We are seriously adrift on this, and I just wondered if there was anything that you could offer by way of improvement that might be possible. And then on PADR, I note that we're below the acceptable percentage. I take this quite seriously because that's the first line of assurance for this organisation, that everyone's working, as it were, towards the top of their licence. And I regard that with a certain degree of seriousness. And then my last point, for paediatric patients awaiting audiology, I take it that these are not complex cases, but I just like reassurance that there's some active case management actually going on. I'll pause there. Thank you, Nicola.
Thank you. 4 elements there, I think, issues. So patient experience, I don't know, maybe Paul to come back in. Colonoscopy, Elaine, PADR, Deb, and audiology, Claire Madsen, if Claire's on the call, if that's okay, Chair.
Please. Let's go in that order then. So Paul.
So again, I think, Ronnie, your question was on the percentage of patients that respond to Civica. If I heard you that correctly, I would have to go back and go into the paper detail, but I will certainly do that for you. And if I can't answer it before PECs on Tuesday, it'll certainly be brought up in that space as well. I do recognise that we are 9th in Wales, and we have a lot of work to do to improve that gap. And I'm hoping when we get our data out that, again, we're looking at May data there. So that's over 3 months ago. So I'm hoping we'll have improved our position, but I haven't seen the new data yet to confirm that. Other than that, I absolutely acknowledge we have an awful lot of work to do still in patient experience, but I still feel confident that we're now pointing in the right direction and we're on an improvement trajectory.
Thank you, Paul. Who was next? Was it Deb? Elaine. please.
So I'm not Deb, so I'll come in terms of colonoscopy. And Ronnie, your question was expected. I think there's a very genuine challenge that we've got here. We've spoken about it previously. We have challenges, particularly in terms of clinical capacity, and that's externally bought in. There's a few key actions that we've got in train. So we've got in train mutual aid discussions, particularly around how we could better use some of our treatment rooms and capacity and support a growth in that clinical capacity for us in Powys as well as other organisations. We are part of the All Wales Bowel Screening Review. That work is ongoing, so there's no outcomes of that at this point. But most significantly, I think for us is we're working with Anara and Bevan in terms of looking at a joint consultant and appointing them. That would give significant additional capacity and support that increase. We bumbled along below 10% for most of last year, apart from the last couple of months where we managed to see an increase. So it is, and it remains our ambition to significantly increase in this area. I think it's really important to note, particularly for the team, who is fantastic in Powys, that when we work with Public Health Wales and when we've been reviewed by Public Health Wales, we get a really good response and report in terms of the quality of our service. It's our capacity that is causing us a constraint. So we will continue with those actions, Ronnie.
Thanks, Sil. I don't want to, Ronnie may want to come back. Can I just ask you, because the possibility of that shared consultant appointment has, I mean, that ambition has been around now for a little while, hasn't it? I mean, what could we expect to happen and when?
I haven't got the detail with me today, so I can follow up in terms of that detail. This is more considered and active in terms of that ambition than any other time since I've been here, but I'll feedback on the exact details around that.
Thank you. So is Deb going to come in now on the PADR matter, please?
I will, yes. Thanks, Ronnie, and I understand and share your concern. You will have seen over the past few years that we've always been relatively stable on PADR at about 82, 83%, so 79% is a dip for us. You know, the reasons behind that will be absences, some vacancies and competing operational pressures, but none of that is an excuse. So I'm hoping that this is not a trend, that this is just a moment in our year. And I know that my business partners will be working with operational teams, looking at their trajectories to get us back on track and at our previous performance levels. Credit to 6 of the 17 directorates, though, in the same period, who are above the 85%. So it's not all areas. We just need to do some targeted work.
Thank you. Ronnie, do you have any additional comment you'd like to make?
Sorry, I'm just waiting for a response on the audiology aspect.
Okay. Is that Claire?
Yeah, I can come in.
Yeah.
Hi, Ronnie. Thank you for your question. I think we've had this query before. Within Powys, we only provide simple ear care assessments, and we commission all our complex services out of area. It's a very, very tiny service. I think I've said that before, and it easily creates delays when we have any amount of sickness or even summer holiday times. So there is a plan to catch up those appointments, but it's a very fragile service and the percentages go down very quickly when somebody's not around. But just as an assurance, there's no complex acute patients on that list.
Thank you, Claire. As you say, we've talked about this before. From my perspective, my driving point here is that this can have a serious effect on life chances for children, developmentally and in all sorts of other ways. So I continue to express concern, and I hope you think that's legitimate.
Absolutely, and just as an assurance, we are reviewing the whole audiology service to look at the skill mix of the service across the whole of Powys and how we can improve it, because we're aware of that ongoing challenge we have with the very small numbers and what we can do to mitigate it as a whole service, not just these managing these acute issues as they occur. So we should be able to bring an update around the whole audiology service in the next few months.
Thank you, Claire. Carl, if I may, I'm just going to come back to Elaine for one moment on the colonoscopy aspect, and just say that for me, the issue of colonoscopy is, of course, that it's not a pleasant experience for patients, anything but actually. I've talked to scores of patients who've undergone that procedure. So I think whatever we can do to ensure a speedy service and a service that reassures them is fundamentally important. And it bears directly on the patient experience dimension, which we've just been reflecting on earlier. Thank you.
Thanks,
Thank you, Ronnie.
Thank you, Ronnie. I think that concludes the contributions from board colleagues. And so any closing remarks from you, Nicola?
No, thank you, Chair, and thank you to colleagues for the comments and questions.
Thank you. In which case, let's go to the recommendation, and that's that we discuss the content of the report. We've certainly done that. That we take assurance that the Health Board has appropriate systems in place to monitor performance and to respond to relevant issues. Same request, please, colleagues. Do indicate if you would like to comment, or if you would, if you don't support the recommendation. That therefore is supported once again unanimously. We're not going to deal with item 3.4 on our agenda today because of a couple of administrative matters. We've needed to defer that, and we will come back to that very important report at a subsequent meeting. So we turn now to item 3.5 and the annual Welsh language report, and Deborah is going to introduce this to us.
Diolch, thank you, Carl. So just to say that this is an equally important report. Colleagues will have seen this as we produce it annually. It has been recently scrutinised by People and Culture Committee, and in case of any technical questions, I'm supported in this meeting by Dr. Adam Pearce. So as I said, this report is published annually and is a statutory requirement under Welsh language standards. The report outlines the steps we've taken during the year to not just comply with the standards, but also to improve our services and our use of Welsh. So just by way of some highlights from the year, we've had the completion of the upgrades to the telephony infrastructure, thereby allowing callers now during working hours to be routed to Welsh-speaking call handlers to deal with any queries that they may have in their preferred language. An introduction of new AI-enhanced translation software, which has increased the capacity of our in-house translator. And for the third year running, we've broken our record for the numbers attending non-mandatory Welsh language training and development sessions. So should board approve this report today, then it would receive the necessary kind of translation and publishing on our website, which in itself is one of the standards. I'll pause there and happy to take any questions or comments. Thank you.
Thank you, Deb. Colleagues, well, actually, before I open it for general discussion, you said, Deb, that this has received detailed scrutiny in our People and Culture Committee. Jen, as chair of that committee, I just wondered if you had any additional kind of words of assurance for us, reflecting the discussions that you had in your committee.
Thank you. We had a really good and full discussion about this at committee, and the committee were pleased with the progress. I think the only one additional comment I'd make is that we talked about the desire to move from compliance to culture, which is where we're looking to deeply embed the strategic elements of the strategic plan about Welsh language provision and use of beyond compliance into culture. That's not going to happen overnight, but hopefully this board can see that the steps that we're making and have been made by colleagues across the executive, that our compliance is improving, and that's really good. Our next step is to focus on embedding that compliance and embedding that right across our culture. So that'll be the next sort of focus for us as we look at that and we consider our annual plan next year. Thank you.
Very helpful. Thank you, Jen. Rhiannon, please.
Yeah, apologies, Deb. I can't recall this particular point in the People and Culture meeting. I just wanted to understand a bit more around the clinical consultations, because obviously getting to the level of Welsh, in terms of greetings and things, and being able to support a proper clinical consultation in Welsh. I mean, there's a lot of mileage for a lot of people, I'm sure, to be made there. So I just wanted to have an understanding of where we're actually at and what we're sort of expecting that journey to. I know the strategy is over 24 to 29, but just kind of where are we now and what we can expect.
Great, thanks, Rhiannon. Adam, can I bring you in, please?
Yeah, absolutely, Rhiannon. Yeah, that's fine. So as you point out, the strategy is a 5-year one. It's a strategy requirement that we all have. The Decent Health Board has a strategy for 5 years. You're absolutely right to say that it's a very long way from sort of going through sort of Bwrdd to being able to deliver a clinical consultation. We are probably, it's fair to say, at a fairly early stage in a lot of those things. For that reason, our strategy for that 5-year period, which will be renewed, by the way, at the end of that, there'll be another 5-year plan afterwards. It is focusing on relatively sort of laying the groundwork, if you like. So one of the things that we're looking at is sort of increasing the emphasis on Welsh in our recruitment, and looking at sort of trying to get recruiters to emphasise Welsh language more in the way that we're recruiting staff, because it's actually I like to use the comparison. It's actually easier to train a Welsh speaker to be a nurse than it is to train a nurse to speak Welsh. So, for example, one of the things that we've been doing is we've actually been advertising our aspiring nursing programme. So the places on that are side for Welsh speakers specifically, and we've brought in a few additional people on that, and that's I believe that is the first time any NHS Wales Health Board has advertised a vacancy for a nurse effectively here as a Welsh central post. So we're sort of slightly pioneering in that respect, I suppose.
Thank you.
Thank you both. Just a quick comment or question from me, if I may, probably to Adam, and just wondered how things are in terms of our commissioned and contracted services. And so I know that work is going on in terms of particularly for the services we commission over the border in England, but also our contracted services in Powys in terms of primary care and others. I mean, just I know it's a very general comment, but is the trajectory where you would want it to be?
Yeah, I mean, it's difficult to measure really, because we don't, the honest answer in many cases, particularly in terms of those services in England, is that we don't necessarily know. When we commission an individual's healthcare over the border in England, they actually fall outside of the remit of the standards, and the organisation there are not under any obligation really to let us know sort of what provision takes place for Welsh speakers in England. Basically comes under equality legislation, and those kinds of considerations. Anecdotally, we do hear occasional sort of stories of which are really promising, actually, of sort of individuals speaking Welsh sort of able to be sort of young children, for example, who are in Telford, for example, being able to be sort of paired with what's being stuff there, but it's not really recorded in any kind of systematic way, and there isn't any system that obliges those services to do that. It's somewhat similar when it comes to primary care. We know that the provision is obviously probably quite a bit better because of the availability of local staff, but the requirements of the around Welsh for primary care, again, is outside the scope of the standards. It's a separate set of obligations which are a bit more voluntary based rather than sort of stuff that we have control. But via the primary care team, and we do offer sort of training, and we do offer, there are various things that we as a health board do offer out there to primary care that facilitate the use of Welsh in their settings.
Thank you, Adam. So Katie, would you like to comment, please?
Just very quickly, Chair, an observation on what Adam said. We do hear quite regularly of issues, particularly with an older generation from rural parts of North Powys. We do hear issues quite regularly about the lack of availability of being able to communicate through their language of choice, which is in their cases Welsh. So it is something that we have picked up with the health board and appreciating the challenges, but it is something I think that needs to remain on the radar.
Thank you. Thank you, Katie, and a big thank you, Adam, and thank you to you, Deb, and please convey our appreciation, Adam, to your colleagues as well. It's a very comprehensive, very helpful and very encouraging report, so na diolch o galon I chi ac a pawb yn eich tîm yn dechrau, so os newch chi gyfleu ein diolchgarwch, byswn ni'n diolchgar iawn.
Yeah.
Good. Diolch yn fawr I chi. So, colleagues, we're asked to approve the annual Welsh Language Standards Monitoring Report for 25 and 26, and to take assurance from the progress made against the plan. Any comment or anyone wanting not to approve the recommendation? That too is supported unanimously, and so we turn to Helen and to her corporate governance report. Thank you, Helen.
Thank you very much, Carl. So a shorter report from me, colleagues, for this board meeting. You'll see that there is the normal report of board activity referenced in there. Two other items just to draw out for you. One is that a single chair's action has been taken by you, Carl, as the chair of the board since the board last met in May. That was in relation to some joint commissioning committee governance documentation that you can see as listed in the report there. And then the only other thing to draw out, just in relation to the health board's petitions protocol, you can see my update there in terms of some work that we've been doing with the Health and Social Care Scrutiny Committee and the County Council. And just also to provide you with an update, at the time of writing, I reported to you that the County Council had taken an urgent motion in the Chamber on the 9th of July. At the point that I wrote the report, Carl, you as chair hadn't received any communication from the chair of the council. That has now come in earlier this week, and I know, Carl, you will be responding accordingly. So just to update members on that. But very happy to take any questions. Thank you.
So, colleagues, does anybody want to ask a question, make a comment, contribute in any way in response to the Director of Corporate Governance report? No? So thank you for that, Helen. In which case we're asked to receive this report, to ratify the one chair's action taken since the last meeting of our board, and to note the update provided in relation to the Health Board's petitions protocol. Again, I'll pause. Should there be any comment, or should anyone want not to support the recommendation? That is supported and unanimously. We turn to item 3.7, which asks us to consider the minutes of previous meetings. There are two sets of minutes for our consideration. I'll take them separately. First, the minutes of the meeting on the 20th of May. Initially, for accuracy, does anybody want to suggest any corrections or changes to the minutes? No, so they are accepted as a correct record. And then the minutes of the 24th of June, same question. Are there any accuracy issues? Ronnie, please.
Thank you, Chair. This is just a very small point. I'm down as an apology for absence until 12:56. It's a bit of an odd way of putting it there. From my perspective, I'd like to make it clear I was present until 12:56.
Okay.
I don't know, maybe that's just a standard way of recording it, but it just looks odd to me. Thank you.
Thank you, Ronnie. Yeah, it's the inverse that we will we'll slightly change that. So thanks for that. If there are no others, then with that one change, then we'll accept those as a correct record. I'll assume, unless anyone wants to come in and say otherwise, that there are no issues arising from either of those sets of minutes that haven't already been dealt with in our agenda, either in the action log or at other points in the agenda. So those are approved. The consent agenda we will deal with as described. So those items are supported en bloc. I'm not aware of any other business, and therefore that concludes the business for this meeting. Just before we draw the meeting to a formal close, can I just remind everyone and make a public reminder that tomorrow we have our annual general meeting, and that again is a live streamed meeting, accessible and available to the public. It begins at 9:30 tomorrow morning. Helen, do you want to make any comment about the practical arrangements or anything about the AGM tomorrow?
Oh, Carl, thank you. Yeah, really encourage, it'd be wonderful to have as many colleagues and members of the public joining us as is possible. We will be running a live question and answer session within the Teams meeting as well. So all the links are on our website and also on our social media channels. There will be the normal presentation from the Chair and Chief Executive and Director of Finance summarising our progress in the last financial year. And then, as I said, a question and answer session where anybody can ask anything they wish to. So please do join us if you can. Thank you.
Thanks, Helen. So the date of our next meeting is the 16th of September. And just before we leave this meeting, I put to you the necessary motion that will enable us to hold our in-committee meeting immediately after this meeting. This motion is taken from section 1.2 of the Public Bodies Admission to Meetings Act 1960, and it's that representatives of the press and other members of the public shall be excluded from the remainder of this meeting, having regard to the confidential nature of the business to be transacted, publicity on which would be prejudicial to the public interest. Does anybody want to indicate that they do not agree with or support that motion? That therefore is supported. It just remains for me to say a big thank you, as always, to those that have prepared for this meeting, to those that have contributed to it and presented to it, and to everyone for the valuable participation that around some very meaty and key matters today. I do apologise that we took more time than we'd anticipated, but I hope that you'll agree that it was time that we that was needed in order to do justice to the items on our agenda. And so with that, thank you. We will leave this meeting and I will ask board colleagues to join the in-committee meeting and see you in a minute or two. Diolch o galon. Thank you.